It's noon and I will kick us off. Hi, I'm Jen Powell and I am your producer for today. We are proud to be presenting the Contrarian Boston Forum on healthcare. This is an opportunity for us to talk about rising costs, what has been done, what can be done, what's on the horizon, and hopefully come up with some fantastic solutions. And with that, I will turn it over to Scott Van Voorst, the editor-in-chief of Contrarian Boston and our intrepid reporter on the ground who has been covering these hot issues.
Thanks, Jen, and thank you to our panelists here today to talk, the answers, talk about these issues. The issue of healthcare costs has just become, more and more important as the cost of healthcare becomes maybe even the biggest line item for families and their budgets, even more than housing, which is kind of a crazy thing to say in Massachusetts, which is already expensive. So we're here today with Alan Sager at BU and John McDonough from Harvard, John Hurst from the Retailers Association, and Paul Levy, who ran the Beth Israel Deaconess Hospital for many years and is now doing um, addiction treatment in that field. Kick us off today. I think we want to circle back to the news that came out this week with the governor really kind of weighing in on this. I think she's in the middle of a re-election race, and she knows that this is a huge issue for families and people, and it's all part of this affordability crisis, which is real for people here in Massachusetts. And so she came out with it's not really a plan, but enforcing existing law, as Paul was pointing out, that would try to moderate the increase, doesn't cut the cost of out-of-pocket expenses, but aims at moderating the increases in out-of-pocket costs and deductibles. And wondering, what does that miss? What will that do? Will that move the needle at all? And what does that miss? And why don't we kick things off with John? Do you want to weigh in here or jump in?
Yeah,
With
I
your
mean, keep in mind, Scott, there's a big difference out there in the employer world, in the marketplace, health insurance marketplace, depending on where you work, and how large you are as an employer. Are you fully insured? Are you self-insured? Small businesses in particular are hammered in Massachusetts because really only in Massachusetts do we put small businesses together with individuals in what's called the merged marketplace. So there is a natural cross subsidies from small businesses and their workers to individuals. That doesn't exist. Didn't exist prior to Chapter 58 here in Massachusetts. Doesn't exist in other states or under the ACA. So you have a disproportionately effect on small businesses because they have that premium cross subsidies, and they also get hit by state mandates. They can't escape them. Nearly 60 of them here in Massachusetts now. Which you can escape if you're self-insured or at least mitigate. So, there is a huge impact on small businesses, and most 62% of our members now are already on high deductible plans.
Hmm.
So, you talk about cost sharing and, on high deductible plans, copays, they're already at their limit. What they're really interested in, and what would have been more helpful than limiting the growth of copays and deductibles, limit the damn premiums.
Hmm.
Let's do something to stop the premiums, which now, if you're not on a high deductible plan and you're a small business, we have members that are $47,000 premiums for family policies now,
Hmm.
and we're going to be looking at, in January 1, they're probably going to go over 50 grand. That is just unacceptable. If you work for a big business, if you work for government, the cost is far lower. We've got to find a way to help these small businesses and
Hmm.
get them relief because they're on the edge of going out of business. It's their top cost issue that
And we have
makes them least
two.
competitive.
Yeah, thank you. And we have two professors here who've studied this issue for years, the cost issues in healthcare, the healthcare system. Um, John or Alan, do you want to jump in on this or just kind of give us an overview of how did we get to this place where it's become just so expensive for businesses and families to afford healthcare.
So this is John McDonough from Harvard School of Public
Yep.
Health. I just want to add, I totally agree with John's statements about the difficulties of small business. I would just note, this is a national problem. There's not a
Yes.
state in the country where you go where small business isn't significantly more besieged with the impact of healthcare costs than any other state. It's a national problem, and can't be. It's going to be very difficult to deal with it just in terms of one state.
Right, and that's interesting because states are limited, even a major state like Massachusetts, and what it can do. Are there any federal? I mean, that sounds like a kind of wishful thinking. But is there any federal proposals at this point that might get at this issue, or are we just in a stalemate right now? Nothing really happening.
I think there are plenty of proposals around from right, middle, and left, and the difficulty is coming to consensus in a state at the federal level with approaches. But I think that the number one issue to deal with and address in terms of affordability is going after mechanisms that will constrain, control, or even reduce, although you hear a lot less about that, about the actual premiums and the cost of healthcare. And lots of different approaches and ways to deal with that, and lots of disagreement about how to do that.
I think the
Alan,
background.
you've looked at the state level for many years. I mean, how did we get here, and what is there anything at least the state could do, or more do, or the governor could do on premiums, or just trying to reduce the kind of dramatic increase in overall costs and insurance premiums for ratepayers?
Scott, so much is going on here. We spend as a country twice as much per person as the rich democracy average. They cover everyone, we don't. They have lower out-of-pockets. In our country, many of us are in love with free market solutions to healthcare problems. And I would be if we had a functioning free market in healthcare or could get one. But just as free markets don't work in healthcare, government has, despite the terrific efforts over decades of John McDonough and your friends, government doesn't work in healthcare effectively. And you get talk from the governor about slowing the rate of increase in out-of-pockets. But that's just public relations. Without a functioning free market and without competent government in healthcare, we have anarchy. And anarchy is why half of healthcare spending is wasted. The way to make premiums affordable is to contain the cost of care. And the way to contain the cost of care is by squeezing out the waste. Unfortunately, the clinical waste, the paperwork, the high prices of drugs and other things, and the theft are baked into healthcare today, and it's hard to squeeze that out. And I don't think we will until the political and financial pressure becomes great enough, and that will happen, I'm afraid, at the bottom of a crisis. We used to hear it takes a village. In healthcare, fixing takes a crisis.
Yeah, interesting. Paul, you've seen these, and you continue to see these cost pressures from managing, medical facilities. But what do you see in terms of like people are griping about costs, and they may love their doctor and think the care is great, but they just can't afford it, and they might they blame insurance companies, probably maybe the hospitals, but is there any single party here that's driving up the costs more than the others, whether it's hospital consolidation or insurers or just bad government regulation?
Let me try to provide a overall framework and then bring it to Massachusetts. So what we have in Massachusetts, in the US, and in other developed countries is the perfect storm of an aging demographic. We have the baby boomers like me and some of my colleagues here who are demanding customers in terms of the healthcare system. You know, if I like to play soccer, and if I hurt my knee, I expect to get my knee fixed so I can keep playing soccer. Whereas my father at my age wouldn't even have thought about doing that, right? So we're demanding. On top of that, and these are worldwide trends, on top of that, we have new drugs that are being developed all the time, which perhaps over the lifetime of a patient would be are cost efficacious, but because we pay for that upfront, we incur the cost burden and we don't see the benefits till later. Um, and the same for devices and the like. Here in Massachusetts, although our costs are very high, our state income is also relatively high. And actually, in terms of the cost burden per family on average, and I don't, averages are averages.
Sure.
We're actually below average, below the national
Yes.
average in terms of the cost burden, and we get strange things like if you were to list the cost to rank the costs of emergency room visits across the states, Massachusetts is like number 46, down at the
Wow.
bottom. So, but that's not an excuse to say that we should claim victory.
Sure.
Um, Also, I think Alan and John and John have made this point too. The legislation that, for example, limits the growth rate in out-of-pocket expenses is a form of whack-a-mole. You knock down one cost increase and it pops up somewhere else, and John Hurst members tend to see a disproportionate amount of those cost shifts for some of the reasons he was talking about. So, what's in my view, there are two underlying problems in Massachusetts that are contributing more than perhaps in other states to high costs. One is market concentration. The healthcare industry in Massachusetts is extremely concentrated, starting years ago with the Partners healthcare system. The legislature baked in the cost advantages of the Partners healthcare system over 10 years ago when they said health systems could only rise at a certain percent relative to their base amount, and the Partners base amount was already well above everybody else. You have the BI Leahy merger, and now Dana-Farber with them, which frankly was designed to create a duopoly in the state. And while BI Leahy agreed for several years not to raise their rates, I think it was a 5-year period, the 5 years is over now. And so we're going to see cost pressure from them. So one approach to this, and across the country, there's ample evidence, like from Marty Gaynor at Carnegie Mellon, that when you do these kinds of mergers and market concentration, instead of lower costs and better quality, you get the opposite. You get higher costs and less quality. So I don't know if there's ever going to be the political will to break up these monopolies in Massachusetts using the antitrust laws, but there's a nuclear option if we want to pursue it. The other thing that happens is the academic medical centers in particular, with the new cancer infusion drugs and those kinds of drugs, mark them up tremendously relative to their costs. Not
Hmm.
100%, not 200%, but sometimes
Mhm.
300, 400%. And then those costs get passed along to consumers. Um, and they often use a preferred drug purchasing status to get a lower price in the first place so that the margin they make on those things is even greater. Vermont just passed a law prohibiting that,
Hmm.
limiting the markup on infusion drugs to 120% of the underlying cost. Massachusetts might want to consider that as well. Anyway, those some starting ideas for you, Scott.
Sure. Yeah, that is interesting. But as you mentioned, Paul, it's also a game of whack-a-mole, right? I mean, if you limit it there, is the system built in a way that then the hospitals are looking to recoup their revenue in another way.
Well, and as long as they have the market power, the insurers are going to give it to them.
Yeah.
Because the thing you don't want to lose as an insurer is a major medical center as part of your network.
Mhm.
The insurers, I think, and I respect the people who run them, do not have a tremendous interest in cost containment in Massachusetts.
Huh.
After all, their profit is also a percentage of the premium dollar that they collect.
Yeah. So that's a perverse or incentive that's not working on behalf of their ratepayers. I'll just throw it out there. So the governor's talking about out-of-pocket costs, co-pays, and certainly they've increased. Um, what would be your suggestion if the governor came to you and said, uh, I need a plan for premiums. I'm hearing back, that people are saying, look, that's great, but I'm having these double digit increases in premiums. What would be your advice? Does anybody want to jump into that? How to
I
control
think there's
premiums?
really two avenues here, Scott, and I guess I would advocate for a combination. One is that, those people paying the premiums should be the ones that have the right to choose what they want, what they need, and what they can afford as far as health insurance. We took away those decisions. Some of it going back 20 years ago with Chapter 58. That has been added on each and every year. We just passed legislature passed 7 new mandates in the last session. Things that have to be in your health insurance, and 24% of our premiums today are Massachusetts specific state mandates. You take those mandates off, and you can, if you are self-insured, you can cut your premiums 24%. Let's get government out of the decision making and make and allow the actual subscriber, the premium payer, not government, not politicians, not the providers, not the insurers, not even the employer. Let the subscriber decide what they want, what they need, and what they can afford. And maybe they don't want to buy all the latest name brand drugs. Maybe they only want generic drugs. That's all they ever need. They don't want to add to all the multi-million-dollar TV fancy ads. Let them buy what they need. Let them buy limited networks to knock out some of the more expensive hospital chains. You got to change the law there and make sure there's a network adequacy law that allows the high cost providers to opt out of that. So you can't really have good limited networks. You gotta empower the premium payer, and then you also need to look at some caps on where the rates are going. A lot of it is payroll, Scott, and there's a lack of interest on Beacon Hill to say no to the big healthcare unions. I know people like Paul and you, Scott, have looked at the education side and the power of unions on that side. Well, that's nothing compared to the healthcare unions that, never seen an efficiency that they ever liked and would never permit a service to be rolled back or a hospital to close that's even underutilized. We saw that with Stewart. We've got to really put in the forefront the actual premium payer and the taxpayer,
Mm.
not the providers and not the politicians. And we need to shift the dynamic to put the priority in the hands of the premium payer and the taxpayer.
John McDonough, Professor McDonough, what would you say to the governor, and what do you say to what John is saying about one way would be to provide more, create more of a consumer and choice that would then create maybe a little competition or some way of moderating costs that seem to be kind of just driven up by some of the bigger players in their dynamics.
Well, I think it's important to understand that it's not an either or, in the sense that there are some benefits that used to be not required. And when they were not required, nobody could get them because you'd have to buy a policy that baked that in. So prior to the Affordable Care Act, no insurers were required to cover prescription drugs. No insurance policies had to include behavioral health, mental health, or substance abuse. No policies had to include things like maternity coverage. So I think that there's a level, yeah, it's possible for a state legislature to go too far and maybe get a little bit too micro, but then there are certain kinds of classifications of benefits that you really need to do if you think that it's important for people to get it, because if you don't make them mandatory, then they'll be in no insurance at all meaningfully.
Alan, what do you think?
Few things. First, no country has ever contained healthcare cost without covering everyone solidly, and no country has ever covered everyone solidly without containing healthcare costs. Our country really hasn't done either one, and that's one big reason we fail at both. I think that if we allow people to choose which benefits they want, that works until you get sick or you're in an accident and you find yourself with huge out-of-pockets that bankrupt you. Unless rich people and young people and healthy people subsidize poor people and sick people and old people, healthcare is unaffordable. And that's the kind of intergenerational social compact that every other rich democracy has adopted. Another key is capping spending and putting the money in the hands of doctors and hospitals under arrangements that allow us to trust them to spend the money carefully, weed out the high-cost, low-value care, and make effective care that works affordable for everyone. If we marry cost control with coverage, which we have not yet been willing and able to do, because covering everyone has been such a hard job that, as John knows better than I do, you run out of oxygen in the room, and there's none left to contain cost, which makes coverage for everybody unaffordable. And so we staple insurance cards to people's collar, plastic cards, and then we suppress actual access to care with high out-of-pockets, high premiums, narrow networks, lack of primary care. One key step would be affordable primary care for everyone, because primary care means lower cost, better access, coordinated care. And it's one of the things everyone talks about, but no one does anything about. So primary care and affordable care for all is like the weather. We talk about it, but until the crisis hits, we won't do effective responses.
But is there
may I jump in, Scott, here?
Oh, yeah. Yep, definitely.
Both for the sake of being a little controversial, but also in order to get us to test our own assumptions about things. I remain convinced that a great portion of the problem in Massachusetts has to do with market power, with the fact that primary care networks are tied to academic medical centers, and so that patients and their primary care doctors don't really shop around for the best quality and cost of service that's available. Given the ubiquity now of electronic medical records and the idea that those records can now be interoperable, there's really no persuasive reason that a primary care practice in any community has to have an exclusive relationship with a tertiary hospital in downtown Boston. In fact, those hospitals should be more like Switzerland. They should be neutral, and they should be competing for the referrals from those primary care doctors. And so I'd like to just bring the idea up of breaking the system apart, disintegrating what's now an integrated care delivery system between primary care, secondary care, and tertiary care, putting the power back with the primary care doctors to advise their patients about where they should be seen for imaging, for secondary treatment, for advanced treatment. And then the hospitals would actually have to compete on results as well as price.
How would that be done in terms of legislatively or legally? beyond that, what would be the political impetus for it?
Well, I see it as a pure antitrust case, but I'm not an antitrust lawyer. But it seems to me that if you are restrained effectively from choosing where you're going to receive tertiary care, if you happen to go to a doctor who's part of that network, isn't that restraint of trade in the most common sense? And whether the Attorney General and the Attorney General wants to go after that, or whether the legislature and the governor want to go after that, I'd like to see people at least evaluating that idea.
Look,
Yeah.
we've known since the year 2000. The Boston Globe did a spotlight series, that Golden Handshake series, that talked about how Partners was acquiring primary care physicians practices as early as 2000. We did nothing about it. They did it to draw more patients into their high cost networks. What we need to do is to unravel that, and what we need to do is incent more independent primary care. Let's give them tax credits to set up and to buy the equipment. Let's exempt them from determination of need, the red tape to do that. Let's even give consumers the option to pull out their primary care out of their health plan and pay those primary care physicians directly. There's a growing effort, not only here in Massachusetts, but across the country, direct primary care, far better coverage, far better service, higher quality for the premium payer. If you can take primary care out of your health insurance premium, we're heading towards 15% investment in the primary care. Allow consumers the ability to invest into those practices themselves and give those emerging entrepreneurial practices the ability to not have to deal with the insurers, to take direct pay from their customers and give their customers a better option for their families. It's all about empowering the consumer in my mind.
Alan or John McDonough, do you want to weigh in on that, or?
I would just suggest a tiny bit of history here. Starting in the mid 1970s, Massachusetts went down the road of let's have the state regulate hospital costs and hospital revenue. And we started an adventure that we went down there through several iterations. And it lasted about 16 years until 1991. And it was called state hospital rate setting. And it was quite aggressive. And there were other states doing the same thing. And in 1991, Massachusetts deregulated and got rid of that system and said, we don't want that anymore. We're going to the new thing, the new kid on the block, the new fad, which was called managed care. And managed care was put forward as a better way for the state to achieve its goals of affordability, cost containment, and quality, and moved in that direction. Embedded in the notion of managed care is the notion of networks, of physicians and hospitals and so forth in every direction. So yes, I think it'd be interesting, as Paul suggests, to look down to what if we just threw all that away and went in another direction. I think that would have to be a lot of careful consideration in terms of the impacts, because sometimes you can move so quickly in one direction, you're not paying attention to a lot of the significant disruption which would come otherwise. I agree it's a time to be radical, but again, there are a lot of reasons to be quite cautious, because this is how the system has managed itself now for about 35 years.
Mm-hmm.
And I'd agree with John on that you would want to do it carefully. I will say that the proprietary electronic medical records that have been in place over the last several years have been used by the major hospital systems to hold on to their patients, so that it was virtually impossible for you, if you were going to one of the partners' primary care practices, to have your electronic medical records sent over to Tufts Medical Center. They just, the interconnectivity wasn't there. So in order for this concept that I've been talking about to work, you have to have a total openness between the systems in terms of the electronic medical records. in essence, because absent that, you do need to have a network, or else your data is lost to
Mm.
the people who need to see it.
Alan, what would be your recommendation? I know you've talked about different efforts to reform the system, but how do you get at this problem here in Massachusetts?
It's worth recalling that the Mass General and the Brigham were allowed to merge in 93, 94 without even a public hearing. That testifies to the political power they had then and continue to have. I think efforts to promote competition in the way that John or Paul have suggested are absolutely worthwhile, but I think politically difficult. And what's politically possible today doesn't work, and what might work isn't politically possible today. Therefore, I think it would be helpful to imagine what would we do if we had the opportunity to make the changes we care about. If it takes a crisis, I think we're heading for one in healthcare, because health spending in the country rose by $1 trillion in the last 3 years. We're now spending $1 trillion more per year on healthcare than we did 3 years ago. That's what that 1 year increase equals defense spending. I'm not saying anything is right or wrong, but that's what's going on. If something can't continue, it stops. U.S. healthcare, doctors, hospitals, drug makers are financially addicted to more money for business as usual. And I think there'll be a time at the bottom of a next recession when Congress will say, oh, it's just too hard to borrow. And Congress will probably do something like freeze federal spending on Medicare, Medicaid, VA, and ACA subsidies. If that happens, doctors and hospitals will try to and drug makers will try to raise prices on private insurers, especially small businesses, but big businesses too. But they'll be rebuffed because they're not, doctors and hospitals and drug companies aren't leaving money on the table today. And when that happens, caregivers and patients who were worried about simply not getting care as hospitals and nursing homes go bankrupt will turn on the one source of revenue needed to stabilize healthcare, prevent bankruptcy, and deliver effective care to 350 million Americans. And that entails going after the clinical waste, the paperwork waste, the high prices, and the theft that pervade healthcare today and waste half of what we spend.
I wonder with back to premiums again, because I think they've been rising by double digits over the last few years. They've just risen dramatically. Is this a sustainable situation? And as Alan was saying, may take a recession or some sort of crisis for this issue to get some attention. But how much longer can we go on with double-digit increases like this?
Not
Hi, John.
long, Scott. We just completed a public opinion poll, 600 voters we released on Tuesday, and it was all about affordability. What were the top 3 affordability issues for the voters out there? Number one, they 82% said they would like to see taxes cut to help their take-home pay for their families. 87% thought the legislature needs to roll back healthcare mandates to give them more take-home pay in their paychecks. And 93% thought the legislature should roll back some of the electricity mandates on our utility bills. These are the issues that are making it unaffordable for our families, that are making a lot of them, our youngest or brightest, our workforce, right on up to our retirees, to want to leave Massachusetts. The real premium payers, these are people that are actually paying their own premiums. They're paying their taxes. These are the folks that we're really, frankly, ignoring, and we're in jeopardy of losing them, whether it's New Hampshire or Florida or elsewhere. We've got to start taken seriously these healthcare costs. The other thing I'll point out in that survey is that 75% on the heels of the 20th anniversary of Chapter 58, 75% said we should repeal the individual mandate, the requirement that you have to buy health insurance or you get whacked with a tax penalty because the legislature hasn't controlled costs. 75% no longer agree with that. We did that because we were going after the so-called free riders. Well, who have been the real free riders over the last 20 years? It's been the big hospitals, it's been big pharma, it's been big healthcare unions. It's been everybody that's specialty providers that have looked for more and more, both utilization plus higher reimbursements, more on the backs of our taxpayers and premium payers. They are the free riders that are sucking everything out of the rest of our economy, and it's time to change that dynamic and do it very, very soon.
John McDonough, you had your hand up. What you're on that issue? Is this a sustainable situation? These increases.
So I don't know what's sustainable or not in the sense that I just for historical perspective, I entered the legislature in 1985 and got appointed to the Joint Committee on Healthcare. And that was my first exposure to health policy. And I remember that year very quickly, someone came up to me and said, listen, you just need to understand the cost situation is getting so serious. The system is at a breaking point and we're about to have an enormous meltdown. And it scared the heck out of me because it was a smart person who said it. I don't think there's been a year in the past 42 or 43 years when someone hasn't come up to me and made a similar statement. So yes, it's dire, and it's been dire for decades and decades. And we can say, oh, now it's worse than it's ever been. And in some ways that's true. And in some ways it's not. There is far better coverage for low-income Americans right now through the expansions of Medicaid, far better coverage through the ACA till the recent refusal of to extend the enhanced subsidies. But so, there are reasons why it's much better. There are reasons why it's much worse. But let me tell you one thing that's so much worse now than it was 42 years ago, which is chronic disease, which is how sick Americans are. If you look at the leading causes of death and you think of heart disease and stroke and cancer and diabetes, but if you go behind that and say, what are the leading factors leading to the leading causes of death? Number one is smoking. Still today, number one cause of death across the United States. Number two, exercise, diet, lack of poor nutrition. Number three, alcohol consumption. Opioids, by the way, is several notches down further. If we really want to address costs, it seems to me that we ought to get radical about taxing the heck out of things that make people sick. We need to have steeper taxes on cigarettes, on alcohol, on firearms, on drugs, on unhealthy foods. We just need to be more aggressive. And there's nothing that you can do that is more effective in terms of changing behavior than taxing it.
Well, that and we need to reward people through their premiums for doing the right thing, John, for being, preventing and dealing with their chronic conditions. Instead of hammering them with high premiums for somebody else's cost when they are doing the right thing. We have a sick care system. We don't have a healthcare system. We need to turn this thing around and benefit those and incent all of us to get healthier and deal with these chronic conditions.
John, every country has a sickness system. It's called medical care. And that's what we need when prevention fails, because prevention, as you know, has a 100% failure rate. We can take a step backward on the up escalator by preventing more things. But the reality of healthcare is healthcare. And when we get sick or injured, we need it. And the challenge is, how do we afford it for everybody? Other rich democracies give more care for all people at half the cost and live longer. and they don't do any better at preventing problems than we do. So
I
think
disagree
there are
with
some
that.
real lessons there.
There are places that you look at motor vehicle safety. You look at safe streets, you look at safe driving, you look at the number of deaths from accidents in the United States versus other countries. There are things that you can do. There is absolutely no way to say that we're powerless to do anything. I think we have more ability to address the behaviors that make people chronically ill and sick and dying prematurely than anything else we might say in the system.
John, you're right. We should prevent everything that's preventable. But that won't fix healthcare, and it won't save money on healthcare. It will prevent individual problems, and that's absolutely valuable and essential. But other rich democracies that achieve healthcare for all that's affordable and that live longer than we do so in large part by making medical care affordable for everybody, which means containing cost, relying on primary care, holding down drug prices through government regulation, and they do other things that actually work.
Oh,
Hospitals
but
have budgets.
Yeah, Scott, first I want to just build on John McDonough's point about what's sustainable economically for society. And our old friend Stuart Altman used to tell these stories about when he was a young professor and healthcare was 8% of GDP, and they'd say, oh, we can't go above that. And then a few years later, it'd be 10%. Oh, we can't go above that. And then it was 15%, and then it was 19%. And so Stuart would joke, he said, I don't know what's sustainable. We seem to be willing to pay more and more. Although we don't always get the results we want, there are some things we are getting as results. Diseases that formerly were fatal quickly, yes, have now turned into chronic diseases or gone away. There are forms of cancer that are no longer a death sentence, so it's important to remember that. A lot of what Alan was suggesting always leads to the question of should you have a single payer plan, and then Stewart always used to joke about that too, about someone talking to God and saying, God, are we going to move to a single payer plan? And God says, oh, of course we are, but not in my lifetime. And Stewart always did it with great humor, but with great insights as well. As I've gone around the world, and I've done a lot of work in many of the developed countries, whether it's Israel or the Netherlands or the UK and other places where there is a uniform state-provided health plan, there is rationing of what they offer. There are explicit decisions about what they offer and what they don't offer. We tend to ration here by income rather than by what we offer. And in those countries where there is a national health system, where they ration by what they're offering, there is generally a parallel private system that's emerged for the wealthier members of society to buy the kind of care that we in Massachusetts take for granted. So that's why I started off by saying some of the underlying problems that we face, an aging population, all those kinds of things are pervasive around the world. I think we do have particular problems in Massachusetts, as I was saying, I think related to market power. And if I could just turn a little bit and say, I think what's happening at the federal level now with regard to Medicaid payments and Medicare payments is likely to aggravate things in Massachusetts in two respects. One is that hospitals will be turning more and more to the commercial insurers to make up the difference in what is not being paid through Medicaid and Medicare rates. And a lot of that, and again, is going to end up with John Hurst's members. So we're going to see pressure along that front. Also, our governor and the legislature are now facing some very tough questions about how to meet the new Medicaid budget limits. And unfortunately, they're coming up with things that in the long run will be harmful. For example, one of the proposals from the administration was to cap dental benefits for Medicaid recipients at $1,000 a year. Well, first of all, that's not enough money to pay for good dental care. But secondly, we all know it's been proven over the years that if people don't have proper dental care, their general physical care goes downhill. And if we're hoping for poor people to get jobs and participate in interview processes, frankly, if their teeth and mouth look bad, it's harder to make a good impression when you want to get hired. And so those kinds of steps that might be taken can actually make things even worse socioeconomically and medically. So these are things that tend to be invisible. I'm seeing a lot of it now since I'm doing work in Fall River, which is a community that has all those problems of opioids and malnutrition and all the rest. And I hope that one thing we don't do as a state is to fall into the trap of short-term savings measures that end up hurting people and hurting the budget in the longer run. It's easy for me to say that. I'm not there making those decisions, but I think we have to be very, very careful about where cutbacks are made.
Paul, I think you've really contradicted Stu Altman completely, because government in Washington and state governments in many parts of the country are saying we can't keep paying for business as usual in healthcare where half the money is wasted. And unless, I think it may be useful to, and also when healthcare spending approaches 20% of the economy, it crowds out housing and education and criminal justice, job training,
right.
all the other things people care about. So things will continue until they stop. And then when healthcare, if Congress goes and really caps healthcare spending, including Medicare, in 5 years, will we be ready to seize the political opportunity that the crisis offers to squeeze out waste, to pay doctors and hospitals in ways that allow us to trust them to weed out the low-value, high-cost care and take care of everybody with the enormous money already available? We ration by ability to pay, and we allow people to suffer and die needlessly while half the money is wasted. And that's a tragedy.
And we're getting close to our time here. Back to premiums. What could does the governor at this point or the legislature have any power to cap those increases in a way that wouldn't just be like squeezing the toothpaste tube where it's, coming out another way? And is it that they don't have the power, or it would be just too hard a political fight with insurance companies and hospitals?
They do have the power. They gotta, but again, it's the pushing on the balloon in one direction, but you got to look at the whole picture. You can't just cap copays and deductibles. You need to cap premiums, and to do that, you got to cap what the insurers are paying the providers through reimbursement, and the big pharma companies, and you got to cap what the hospitals are paying to the very politically powerful big healthcare unions, the SEIU, with their $4.5 million political action committee, who at any drop of the budget, drop of the hat to talk about, being efficient, will go to the friends in Beacon Hill and say, well, you can't close this facility, you can't cut back on this facility. You gotta look at all the pictures, all the pieces of this puzzle, and make sure that the entire picture is capped off closer to the economy. Our HBC benchmark has been absolutely ignored, and we have premiums for small businesses that have been about 3 times the state benchmark. If we want to get serious, we've got to make sure that entire a spectrum from the premiums, from the insurers to the hospitals, the providers, the specialty docs, the pharma companies, the healthcare unions are all kept in line with the rest of the economy.
And John McDonough, you were saying, yeah, sorry.
So when you want to talk about what's different about the United States from everybody else, it's that we don't have one system. We have a series of systems that move alongside each other. So if you're over 65 or disabled, Medicare, low income, mostly mass health, Medicaid, individual, you can't get insurance through your employer or you make too much money, you can go through the connector for ACA coverage. And then the largest group are people who get commercial insurance through their employers. That's the largest group. That group is divided between people like in John's population who are mostly buying commercial coverage directly from insurers versus most people who are covered through their employers. The employers are large enough to self-insure. And if they self-insure, they escape any state regulation. So the big problems in terms of controlling costs is not Medicare, it's not Medicaid, it's not even the ACA coverage, it's the commercially insured. It's about 3/4 of that population the state can't touch. All they can touch is for John Hurst's members, for the small employers, commercially insured. And that's where I think, I don't know if you have an agenda, John, for the state policymakers, but it's really kind of, in some ways on your shoulders, what could be done that would really be helpful to your members. But the truth is, understanding is that small group insurance all across the country, 50 out of 51 states, and throw DC into that as well, is disappearing because it's just not an economically sound proposition. One of the things I'd ask you, John, is there's this new thing invented by the Trump administration in their first term called ICHRAs, an awful name, but that's what it is. ICHRAs, individual coverage health reimbursement arrangements. Those are taking off around the country, a little bit in Massachusetts. What's your take on that? Because that's a way for employers to get away from having to pay annual premium increases in the same way and still allow employees to have some choices.
Right. I like the option, John. It's a problem. The problem is that these small businesses are competing with big businesses for the very same workforce. Bring them in, recruiting them and retaining them, and the big employers aren't doing that. So therein lies it's a workforce competitive problem more than anything. I think ultimately more and more will offer that. I think it's a good option, but we've got to look at ways. To your point, John, I think we need to find ways to give these employers, small and large, a reason to stay fully insured, make the fully insured market look more and cost more like the ERISA exempt self-insurance, and that means you got to give the employer, and really more specifically the subscriber, the right to choose on what they want, what best fits for them, their families, and when you have 60 state mandates that aren't covered in other states or under the ACA, we need to John, look at some of that, or at least create guardrails, the ability to mitigate some of those costs.
Can I just say one more thing to John Hurst? And I've watched you and respected you for 40-something year, long time. So good friend. I don't get it. In 2021, the Biden administration changed the affordability standards for people who get insurance coverage through the Mass Connector or any of the exchanges to be significantly more generous than what the ACA originally had, and to have no income cap on top of it in terms of having an absolute cap on your household income of 8.5%. In that 5-year period, I don't get why a single small business continued to offer health insurance to their workers, as opposed to saying, go to the connector, have choices for what you want, and I'm out of it. I'll have to pay some penalty to the state or something, but it's not as much as I'm stuck for now. I don't get why small employers, rationally speaking, are staying in this game at all because they
Well,
don't need
I
to.
think look, we have lost 550,000 small group lives out of the merged marketplace. They've done some of what you've talked about. They've also gone stop loss. They've gone self-insured. Nobody's talking about that. That's huge. That's 66% have disappeared. And some of them have done that, John. But it still gets to the point. Do you see the GIC doing that? Do you see big national employers doing that?
GIC is not a small employer.
Well, I know
GIC is a
that's the
huge
point,
employer.
but it's getting back to, it's like Icarus. You've got to still compete to get that good workforce that serve your customers. You got to compete to recruit them and retain them. And if your big competition for workforce isn't doing that, you've got to other than salary, what is the biggest thing that an employee is looking for when they're looking at an employer? It's benefits, and primarily health insurance. Until large employers are doing the very same thing, it's hard for a small employer to get a good workforce to serve their customers if you're asking them to have a different standard of benefits for their employees.
Yeah,
but the truth is that if you send your workers to the exchange, they're probably getting much more affordable, higher quality coverage than what they're getting through the stinky small group market.
Yeah, well, these are big questions, that's for sure. And I think it's difficult. I think, in our state and nationally, it's difficult. We're not set up for, small businesses don't have some disadvantages. People trying to start businesses have disadvantages. And healthcare can be a big one, right? So it might be something to look at in the future. How do you make it so people can take chances and more risks with new ideas? But I appreciate everybody showing up today. This is a great discussion, and I'll be posting the video and doing a couple stories on it in over the next couple days. But I want to thank you all for taking the time here for a great discussion.
Thanks, guys.
I've certainly
Nice to
learned a
see you
lot.
all.
So
Thank you,
Hey,
Scott.
friends.
It's
Yeah,
been
everybody
an honor to
connect with
participate.
everybody.
Good to see you
Peace
all.
to
It's been an
everybody.
honor
All
to
right.
participate with so many smart and well-intentioned people who have been effective for decades in making real differences.
Thank you.
That's thank you, Alan. That's great. No, it's a really great panel here. Thank you so much. And
I also want to encourage
Sayonara.
everybody, Scott, before you go,
oh yes,
if you are not subscribed to the Contrarian Boston, please subscribe to the Contrarian Boston and share the articles so that we can spread the word about the great coverage that we're doing. And also, if you have story ideas and you have things that you would like, questions that you have, please pass them to Scott. You can find us at contrarianboston.com.
thanks, Jen. All right.
Bye.
Thank you all, and thank you for attending. And we'll be back with some more stories ahead on this. Thank you.
Bye.
Bye.
Thank you all.
Bye-bye.
All right. Let's see. All right. Hey. No, I'm talking to Jen right now.
You need to end.
Okay. All right.
Still.
And